these are the principles of All-on-4, and sometimes people get mixed up a little bit. So basically, we only place 4 implants for a full arch rehabilitation. That everybody knows. We do not use the posterior regions of the maxilla, typically because either there's no bone or the bone is soft. We do not want to use it. And we tilt the implants, the posterior implants, at 45 degrees. We also reduce the bone if there is a smile line showing gingiva. So this is also a characteristic of the All-on-4. We use the cantilever if needed, obviously, so we do not avoid using cantilevers, although you know that if we can place the implant in the posterior, coming out in the molar, of course, that's better. Immediate function is not, it is a characteristic of the All-on-4, but just like the cantilever, it's not a must. Sometimes, due to the case or your level of skills, you are not comfortable with immediate function, so you do not need to immediate load, meaning that just because you don't immediate load, it's still an All-on-4 procedure. And the prosthesis the first prosthesis is full acrylic without any metal, and it has the pink on it. So as you know, this was brought up in 1993. The first case was done in 1993, and these are the characteristics. People know about the 4 implants, people know about the 45, the bone reduction, people get mixed up a little bit and still controversial, I understand. And of course, the prosthesis with the pink gingiva and the pink papilla, it's still a little bit confusing, but these are the 6 or 7 characteristics that obviously characterize the All-on-4. So we have grafting versus non-grafting. As you know, about 20 to 30% of the patients of totally dentless, we cannot graft for many reasons. So we do not believe in grafting for totally dentless. And we have, along the last 20 years, since the first case was 1993, proven that we actually do not need the grafting. So this is a nice schematic view. If you have enough bone from molar to molar, not only in volume, but also in density, and remember, density is more important than volume. It's better to have 7 millimeters of dense bone than 20 millimeters of soft bone. You should go for 6 implants, 6 parallel implants, 1 in the molar, 1 somewhere around the first premolar, another one around the canine or lateral. That's what you should do because it's easier. It's much easier, and it's within your comfort zone. Unfortunately, when you do not have bone in the molar, then, which is most cases, then you should incline the implant so that you have the head of the implant in the molar and the rest on the good bone. If you do not have bone on the molar and premolar, you should do the same. Incline the implant in order to reach further back. Do not be afraid of the cantilever until you get to the stage of you have 2 teeth in cantilever. The moment you get 2 teeth in cantilever, the risk, you can go 3 and 4 teeth in cantilever, but the risk starts increasing. So we consider an All-on-4 standard until we got 2 teeth in cantilever. From that, which means that you have bone from canine to canine, and basically need about 3, 4, 5 millimeters of bone in the first premolar area. That's the limit of the standard All-on-4. Then we go to a hybrid. Hybrid means, 1 implant in the maxilla and another implant outside the maxilla. Can be anywhere you want. The zygomatic approach is the easiest one and the most reliable. So if you take 1 implant around the lateral or central and 1 zygomatic implant, that's a hybrid. Why do you call it hybrid? Because we have 2 different types of anchorage, 1 in the maxilla, 1 outside the maxilla. So we call it hybrid. Some cases, as you know, we have no bone at all. Therefore, we need to go for a double zygoma, or it can be a zygoma and a pterygoid. It doesn't matter. We just call zygoma, but in fact, there's many other opportunities around the face to use it. But it's a double zygoma. It can be if it's a double unilateral or double bilateral. If it's a double bilateral, of course, we call it a quad zygoma. If it's a double unilateral and just one on the other side, it's double unilateral. This is the protocol we use for the totally dentaless, and as you can see, we do not graft. Well, in medicine, we should never say we do not do that or do this, but basically, it's very rare to graft. We graft cases of trauma very, very seldom. So this is when you have this, this solution where we have like enough bone volume from molar to molar with good density, that should be your solution. 6 implants, parallel, easy going, no problem. You know how to work with this. You've been working with this since you start placing implants parallel, so you should not worry about anything like that. It's very easy. I would advise you in the posterior, premolars and molars, to go for bicortical anchorage. Bicortical anchorage was a technique we developed in 1995. Means that you cross both corticals. For that, you need this type of implant. This is actually the speed implant that you can make a small osteotomy, push the osteotomy with the implant, and break through the cortical. Do not cut the cortical, break through the cortical. If you do not have bone in the molar, as we explained, you just incline the implant so that you can have the head of the implant more posterior and the body more anterior. This way, you can get away with less bone. The All-on-4 is a technique basically developed in the early 90s, as I said, the first case 1993, to use the minimum amount of bone to deliver 12 fixed teeth. That's the idea, the basic idea. So we got some cases here, and just show you some prostheses. It is important to understand also that the more implants you place, the more difficult is the prosthetic work. Because the more implants you place, the more holes you have in your prosthesis. Therefore, you have more mechanical failures and also more complication in terms of aesthetics. The best possible prosthesis in terms of aesthetics is 1 implant and 12 teeth, because this way you can place your teeth where you want. You choose the color, the size of the papilla, the size of the pink, anything you do. It is impossible to compete with a total bridge like this in terms of aesthetics. As you increase the number of implants, you increase the probability of complications, be it mechanical and aesthetics. Why do we place 4? Well, because we can't place 3. And then we have the situation where we have to use outside the maxilla anchorage. We call it hybrid. And you can see here it's a young man with anodontia, meaning that he was born without teeth. And a case like this, we do not have enough bone, but we still can deliver a beautiful bridge, and of course by the using of zygomatic implants. Then we can have the cases where we have no bone at all. You can see that these cases typically are big bridges. Be careful. The surgery is as important for the success of the case as the bridge. And these bridges, the top of the bridge, where the contacts with the gingiva, has 3 characteristics which you must respect. Number 1, as thin as possible, normally about 2-3 millimeters in thickness. Number 2, convex always. And number 3, highly polished. That's the only way you're going to guarantee hygiene. And hygiene is very important. Also remember that these bridges, I've seen in some pictures or some books and articles, the top of the acrylic, the pink, goes up and down. This is wrong. This is absolutely wrong. It must be flat. The more up and down you go, the more surface you have on the base of the prosthesis, which means that you have more bacteria, more food entrapment. The base of the prosthesis must be as flat as possible, convex, polished, as thin as possible. Never make the base of your prosthesis going up and down and up and down. All right? This is not intelligent. You have two types of prosthetic solutions. You can cast your metal or you can CAD-CAM. Casting the metal, you can place more implants and you can make separate bridges. The advantage of separate bridges, of course, is that it's easier to manufacture because you can have like 3 bridges of 4 teeth each. You have to, of course, place more implants. But this way, you do not run away from your routine. You make a bridge on the left, a bridge on the right, and a bridge on the front. Aesthetically, the teeth look very nice. The problem is that if you do this, and that's the case, if you do that, you cannot place the pink papilla. Because, as you can understand, on the end of one bridge, you have to have half a papilla, and on the end of the other bridge, another half a papilla, and when you put them together, the two halves must be together, which is, without Photoshop, impossible. So we have to understand that these types of reconstructions are very difficult to have high aesthetics because you cannot deliver the papilla. To deliver the papilla, you need a full bridge. And a full bridge, if you cast, is very difficult to make it pass a fit. So the best way to do it, of course, is to have a CAD-CAM, like the Procera. And so, therefore, besides the fact that if you chip the ceramic or these bridges, you have to take them out and redo the full bridge. Now, we have developed this Malo Clinic bridge in 1995, I believe, 15 years now, a little bit more. And this basically has 5 characteristics. Number 1 is a full infrastructure in metal. You can have the metal in titanium or chromium cobalt. Chromium cobalt is not flexible. So if it's not flexible, it is not a good material to make a bridge. Bridges and skyscrapers, they need to be flexible. Otherwise, they crack and break. The idea that the bridge needs to be rigid, it's not intelligent. You can ask any mechanical engineer. A bridge needs to be flexible. Okay? Now, chromium cobalt is not that flexible, and zirconia is almost no flexibility at all. So if you would like to do bridges like this, the full infrastructure, you should try and do titanium because it's very resistant, but it is flexure. Then the teeth are placed one by one, ceramic. It is screw retained. I understand that if you cement it, you allow yourself to not to be so precise. And these are the type of bridge that you should try to place in the future, because if you break any ceramic, you do not need to remove the bridge from the mouth. You take the impression in the mouth, you place a provisional crown, and you ask for another crown in the cement. The bridges come from the lab. The crowns are placed under vacuum and pressure, but you can do it, repair in your office chair side. This is what ends up. Thank you very much.